So the updated guidelines have basically stated that we need to add more medications to our preferred drug list so that providers have access and members have access to those medications to ensure that those with comorbid conditions, not just diabetes, but hypertension, hyperlipidemia, or previous heart attacks or strokes, have access to one or more medications to ensure that downstream we reduce the risk of subsequent complications. And so at WellCare, again, we make medications in these classes available to our members to ensure that they receive the care that they need in the most cost-effective way. Again, guidelines are just a tool, a reference point. When a clinician evaluates a diabetic patient, the treatment plan or care plan is very individualized. There are certain medications that are more appropriate for a diabetic and not appropriate for another, depending on whether they have concomitant hypertension, concomitant heart disease, or concomitant renal failure. And so as a result of these carve-outs, it's very difficult to sort of paint the entire diabetic community with one brush at one color. It is very individualized, and medicine is still an art, and it does require some artistic ability and clinical acumen of the physician to design an appropriate individualized care plan. Again, so at WellCare, we partner with providers for that very reason. We don't anticipate that they will treat all of our diabetic members the same. Our hope is, again, to use proxies for care, such as A1C control, blood glucose control. These proxies give us a guide of how well you're managing the clinical outcomes of those diabetics. And so we're not expecting the clinicians to use the standards literally. We expect it to be used as a guide, and then from that guide, carve out those appropriate elements that you need to still hit the target